For our listeners, this is a content warning. Throughout this podcast, we touch on subjects related to trauma, misogyny, racism and medical racism, sexual misconduct, residential schools, as well as many aspects of death and dying. Should you need them, there is a list of resources in our show notes. Most importantly, as you listen, take a break when you need to, and please take care of yourselves. We'd like to acknowledge that this podcast is produced and recorded across the land known as Canada. These traditional and treaty territories are full of rich Indigenous histories, home to many diverse First Nations, Inuit, and Métis peoples. We embrace the opportunity to share this story in a respectful, inclusive, and culturally appropriate way.
I'm Danielle Wilson-Brown. This podcast is about my mom, Marion Brown. She is a visionary, perpetual student, the biggest nerd, and adventure seeker. She is in a one-life stand with my dad, Fred. She is a mother of 3 and new grandmother of 2 beautiful grandbabies. She is a TV and film producer, former musician, family therapist, governance consultant, and soon-to-be ex-council member of Githatha Nation in BC. Oh, and by the way, she also has pulmonary hypertension. There is no cure, and it will take her life. And so, we're going to share our story and this end-of-life journey with you. I hope you'll join me, Danielle Wilson-Brown, my mom, and some special guests as we begin to discuss death, dying, and above all, living. Welcome to Before I Go. Today, we have a very special guest, and I'm really looking forward to having this conversation with Mom's nurse practitioner, Lisa Kolkman. How are you doing, Mom?
I'm good. I'm just feeling really good today. Today feels like just one of those things that's supposed to happen. You know, when you open yourself up to whatever happens in the universe or whatever the universe points your way, you just jump in with both feet. So today is just one of those where I don't plan everything. I'm just open to whatever.
I am dealing with a respiratory virus, and so you'll have to excuse my raspy voice today. But thank you so much for joining us today. I'm really looking forward to this conversation. And you, Lisa, have played a huge role in how our lives have been shaped, for the past decade. I was hoping you could give a bit of an introduction and some of your background, some of your accomplishments.
So I've actually been working in the Pulmonary Hypertension Clinic since 2012, so for the last 13 years. Well, I basically went from high school into university and worked as a registered nurse from the age of 18. The role of the nurse practitioner has been around in the United States for much longer than it has been in Canada. And so they started looking at how can you take someone like me who has 10 to 12 years of experience working in the medical system and knows so much about different diseases, different conditions, different processes, but just needs a little bit of training to kind of change from monitoring a patient. So here's the treatment plan. This is the expected outcome. Is the patient following along this process? To creating a treatment plan for a patient. So coming up with a diagnosis and a treatment plan. So some nurse practitioners train to become primary care providers and become generalists. Some nurse practitioners work in a specialty center such as mine, where there are physicians, nurses, pharmacists, a whole healthcare team. You work as part of a team to improve care for the patients suffering with pulmonary hypertension. And I have to say that a large part of my career here in the Pulmonary Hypertension Clinic, or working in the world of pulmonary hypertension, has largely been driven by patients like your mother, like Marion, and your family, because it was actually your family that really pushed my interest in genetics in the genetics of pulmonary hypertension. So I have to thank you for that.
That's great because, we definitely have an interest in that also because, it's something that my sister had, it's something that I have, and now I'm concerned for my daughter and my granddaughter. So genetics is a huge component right now to how we are going to navigate through this as a family.
We've talked about in this podcast how mom was diagnosed with pulmonary hypertension. I'm hoping throughout this conversation, we can really let people know what that is, and how that impacts the patient and how it impacts, the family around her. What's your driving force to work in PH? And what is PH?
When I returned to Canada from working in the United States, I was working in an intensive care unit across the water in downtown Vancouver at St. Paul's Hospital. And there was a intensive care unit physician who was quite interested in me and the fact that I was going back to school to be a nurse practitioner. And he said, "When you're graduated, you come find me, and I will find you a job." About a month before I graduated, I happened to be on a shift with him, and I told him, I said, "Hey, I'm almost done school. I'm about to graduate, write my exams, and I'll be ready to practice in September." And he said, "Well, I know of two jobs. And so as soon as you write that exam and you get that passing mark, you let me know and we'll put your name forward for them." And I said, "Okay." Interestingly, the first job was in a transplant clinic. They were looking for a nurse practitioner to work with people who had had transplants. He said, "The second position is kind of a very interesting position. It's going to be a challenging position. It's in the pulmonary hypertension clinic." And I said, "What's pulmonary hypertension?" So, I'd worked as a registered nurse for almost 12 years at that point, and like many healthcare providers, had never come across a patient who had pulmonary hypertension and had never met or interacted with someone who had pulmonary hypertension. So for me, when I talk about pulmonary hypertension, and I talk to healthcare professionals and I talk to patients the same way, pulmonary hypertension just means high blood pressure in the lungs. Just like you can have high blood pressure in the body, which is very, very, very common, you could also develop high blood pressure in the circulatory system that goes out to the lungs. And these are two separate things. Pulmonary hypertension that happens in the lungs is very rare. There are hundreds of thousands of people in British Columbia who have high blood pressure in the body, maybe only 2,000 or 3,000 who have high blood pressure in the lungs. And the disease is completely different. It's a disease that affects the blood vessels of the lungs. And for whatever reason, whether it's an autoimmune condition, a heart condition, a lung condition, a liver problem, a genetic condition, the signaling systems in the blood vessels in the lungs go awry. And they tell the blood vessels in the lungs to squeeze down. And this causes there to be more muscle cells in the blood vessel walls. And those muscle cells themselves hypertrophy or grow. So we have a patient now who has lungs with these thick, stiff blood vessels in the lungs. So instead of them, opening up or closing, depending on how much your blood or oxygen they need, they're basically constricted most of the time. What happens is the right side of the heart has to kind of, adapt or learn to cope with that high blood pressure in the lungs. And the heart is a muscle. And just like any other muscle, it gets bigger, it gets stronger, depending on, what it needs to do. But over time, it's a little bit like running a marathon 24 hours a day, 7 days a week. The heart muscle gets tired, it gets stretched out, and starts to fail. Often my patients are young, they're otherwise healthy, they live full lives, they have families, and especially if they're women, often when they come into their family doctor's office or an emergency room and they say, something's not right. I feel more short of breath than I should when I'm, walking around or I'm doing my daily activities or I'm getting groceries or I'm picking up my child. Someone will sit across from them and say, "Oh, you're probably, anxious. Maybe you're a little bit out of shape. maybe you're overweight, maybe you're depressed, maybe you have too much on your plate, you have a young family, there's probably nothing wrong with you. And, if it ever gets to the point where someone orders an ultrasound of the heart, it's easy for someone then to make the diagnosis of pulmonary hypertension and send them to our clinic to be evaluated and treated. But this process can take, 3 months, 6 months, 1 year, 2 years. And that can be pretty hard for patients to have to go through that process.
Why is it so hard to diagnose? Because my sister's disease was that progressed very far. And mine took 3, 5 years to diagnose because I was diagnosed with exactly what you said. They called it asthma, they called it allergies, they had acid reflux as one of them, and I was told, to lose some weight. At some point, I did say, "Well, is this what my sister had? Because it kinda looks like what my sister had." And yet the diagnosis was still slow.
Right? Well, I find that particularly amazing for you because it's not like you weren't connected to good resources, right? It's not like you weren't connected to physicians who weren't familiar with pulmonary hypertension. And I could see how that would be incredibly disappointing for you because, you were seeing physicians who should know what pulmonary hypertension is. They should know that there's a familial component. They should know to look for this.
I think sadly, though, when it comes to Indigenous patients, that we have a lot of so-called rare diseases. So, the amount of lupus or when they ask us the history of cancer in my family, it's like my family is the history of cancer. It's we had absolutely everything. So it's difficult to say, "Oh, this is what it might be." So I get it because I have to list colon cancer. I have to list, all the number of cancers that have existed in my family. And, high blood pressure was actually a thing. And then you add the layer of, potentially medical racism.
And I'm also curious what the access is to kind of primary care as well in your community. Like do you feel like you have the same kind of access up north that you would have here down in Vancouver?
You know what? I don't know because there are some ways that I found the doctors up north as overworked as they are because I offered the same, understanding to them that you do. The doctors up north diagnosed my mother's ovarian cancer when the 6 doctors I took her to down here couldn't.
Oh, beautiful.
And
Yeah.
so it was the one she finally got tired of me dragging her to all these different doctors and went to a doctor in Prince Rupert, and he diagnosed her very quickly.
Yeah.
So it's a matter of just, that advocating on your own behalf and just keep on going until somebody hears you.
Yeah. Yeah.
But when it comes to pulmonary hypertension, how many people have it? How rare is it? Because I gotta tell you, it doesn't feel rare in my family.
Yeah, or in your community, to be quite honest with you, that's really what kind of, like I said, drove my interest in genetics because you can screen the whole population of BC and talk to hundreds of thousands of people, and none of them would have pulmonary hypertension. And then you could go to your community and find 8 or 10. When you're looking at rare diseases, like I said, I worked for 13 years in a variety of medical and surgical units across Canada, the United States. And, you know, I never met a pulmonary hypertension patient until right before this was a field I was interested in working in. And I talk to people all the time in small communities like physicians, primary care physicians, nurse practitioners, respiratory therapists, nurses, home care nurses. And they're like, what is this? What is this disease? What are these medications? What are these treatments? How do I help these people, safely in my community? Because I've never seen anybody who's had this disease or this condition before. So we're talking rare when we're talking rare.
I'm Danielle Wilson Brown, and this is Before I Go, a podcast where my mom, Marion Brown, and I have some of the most profound conversations of our lives about her end-of-life journey. what are the treatment options and just like what has been the evolution of those treatment options? Because I remember when my Auntie Jerry was diagnosed, she had a few options, but then years later, when Mom was diagnosed, that number multiplied.
The treatment world of pulmonary hypertension has changed dramatically over the last decade. It's shocking, actually, how much more options there are for patients who have pulmonary hypertension. They knew from like the 1970s and the 1980s that people who had pulmonary hypertension weren't making enough of something called prostaglandin or prostacyclin. So basically, this is a substance that the blood vessels in your lungs secrete, and it helps open up the blood vessels of the lungs instead of having them squeeze down. And so they tried from the 1970s to the 1990s to make a pill version of prostaglandin or prostacyclin. And try as they could, they were never successfully able to do so. They could make prostaglandin, they could put it in pill form, they could take it, and it would never end up in the lungs for a variety of reasons. And so they knew that if you could give, prostaglandin or prostacyclin through an intravenous, it would make its way to the lungs because it didn't have to bypass the absorption, the being turned into an active form in the bloodstream. And so the very first research trial in pulmonary hypertension was for an IV medication called Flolan. Most of the patients who started on Flolan in that research trial got better. And in fact, most of them got so much better that one, they didn't need to stay in the hospital, and two, they didn't need to go on to have a lung transplant. And so, this was a very successful medication, a very successful research study. And it was very exciting for the people working in the field of pulmonary hypertension because they could offer people hope. The problem was when they tried to take them off this intravenous medication, the pulmonary hypertension would come back. And so what we ended up doing, or what this research scientist at the time ended up doing, was figuring out a way to give this medication through an ambulatory infusion pump, a little pump that provides the medication to a patient. And the patient started just very much like you and your daughter and your husband, Marion, learned how to mix up the Flolan into a little cassette, program a pump, learn how to look after a permanently implanted IV line, and then take that home. And at any given time, I have anywhere between 30 to 50 patients running around British Columbia who are attached 24 hours a day, 7 days a week to an infusion pump that's keeping them alive. Since that first research trial, we have many other medications to treat pulmonary hypertension, but that IV medication remains the best medication that we have.
What are the implications of these treatments? What are some of the limitations that these patients have to live with, being diagnosed with PH and then going on to these treatments?
I've worked in the medical field for many years. It's been a huge part of my life. So for me, these are very normal things, right? But I think all the time about my cousins or my brothers or my parents, sitting across from me and having the kind of conversations that I have with patients where, like, first of all, you're 35, 47, 60, whatever age, you have high blood pressure in the lungs. Survival without treatment is 3 to 5 years from the time of diagnosis, right? So, like, those three sentences alone, you carry an entire world in that, like, those three sentences alone. And then you have to continue on, right? So patients who have pulmonary hypertension don't do well with pregnancy. So the next sentence may be, I'm sorry, but you can't get pregnant. You can't have kids. You won't survive if you do that. The next question after that is, are you well enough right now that we can try oral medications, that we can try pills? We'll try one pill, we'll try two pills, maybe three different types of medications that you might need to treat pulmonary hypertension to try to keep the disease under control for as long as possible so that you can live as long as possible, as well as possible. Or are you so sick right now at the time of diagnosis, maybe the disease is very advanced, that we need to start out extremely aggressively to get this disease under control. And I've just told you you have a life-limiting disease. I've just told you you can't have children. And now I need to tell you that you need to start on a intravenous medication to treat your pulmonary hypertension. And you're going to be attached to this intravenous line and this pump 24 hours a day, 7 days a week for the rest of your life.
When Danielle and I were doing this report for PH Canada, it was talking about Indigenous patients. The fact of the matter is that so many of our people have had to deal with medical racism. How is the PH clinic able to help and support Indigenous patients? Because this not so rare disease in our community affects quite a few.
I think that's a really good question. I think one thing that has been helpful for us has been the fact that our program spans like all of British Columbia and the Yukon Territory. And this means that from early on, we were early adopters of technology. So telehealth, teledoc, all of that kind of stuff. So for us, there was none of this. You have to come to Vancouver every 1 month, 2 months, 3 months to get treated. We found ways around that. We work through email, we work through phone, we work through text messages. We will work through, whatever we need to do to reach people. So there's not always this huge expectation. There still is a couple times a year. You have to travel 1,200, 1,300 kilometers to come to this wild, crazy city that's called Vancouver, so you can see your healthcare team. I also think we have come from a low barrier perspective from the beginning as well. When you are the only place in town, so there's only one clinic where pulmonary hypertension is treated in British Columbia, we don't tend to say you need to meet these expectations that we have of you before we will accept you as a patient. It is, you have this disease, you belong to us. How can we make this relationship work? Our goal is for you to be as healthy as you want to be. We would like it if you were as healthy as we would like you to be, but we also recognize the human element in front of us. I won't say that we're perfect at it, and I won't say that having that pandemic hit us, having incredible growth in our clinic, has meant that our ability to support people who struggle with connecting with the healthcare system in traditional ways has fallen off a little bit in the last year. Like, I'll be honest with you, the sheer workload has made what we used to be able to do slightly more difficult. But Vancouver Coastal Health has really supported, that kind of approach to care and tried to support the people that we can access and that we can need. And I don't know whether it's, and maybe this is a failing on our part, that we've specifically sought out better relationships with Indigenous people. I think it might just have overall been the approach that our clinic has chosen to take, or that we have chosen to take as people working within a structure, within an environment.
Mom briefly mentioned the PH report that we did for, PHA Canada. We talked to Indigenous patients and, their experience in the medical system. And across the board, they all had raving reviews. They all had really great things to say about their PH nurses. And so I just really want to emphasize, the important role you've played, and how are you guys feeling throughout this conversation?
I feel exactly the way Danielle does, because I feel like this conversation can go on for a lot longer. And I hope at some point you can come back, Lisa, because this whole podcast has been essentially started because I've decided to use MAID when there is no other medical intervention available to me. I will use medical assistance and dime. And that primarily came from watching my sister and her end of life journey. And this relationship that we've had with you has been well over a decade now, because you were there when she was diagnosed. You were there when she passed away. Can I ask though, because you were talking about burnout. How hard is it? How do you protect yourself from when you lose a patient? How do you not give up and say, okay, I want to do something else?
I think protecting yourself is where burnout starts. I don't think you can protect yourself from the lived experience of patients. I honestly think that burnout comes from trying to separate yourself from what you're doing and trying to protect yourself. It's almost developing that hard core around yourself, um, is where a lot of that burnout starts. For me, I set very hard limits in my life. There are times when I'm available outside of my work hours, but they're for express reasons. And those express reasons are that it's a situation where my presence will make a huge impact, and facilitate something that's good for a patient or the healthcare system. In my life, I do not watch scary movies. I do not watch murders. I'm barely up to date on current events and politics and things like that, because my world outside of my work needs to be very soft. Otherwise, I can feel the stress creeping in and that kind of sense of overwhelm begin. I also think that working in a quaternary care center, you tend to be well resourced. And I think the other aspect of burnout is when you are faced with the moral distress of seeing a patient population that deserves so much and not having the resources, to support them. And there's so much more that we could be doing for patients who have pulmonary hypertension. Like, don't even get me started on my favorite topic. But I think for me, the hardest parts of my career is when I know I should be doing something and I know this is the standard of care and this is how I should be showing up. And I can't, either from demand or something that's happening in my personal life. That kind of tends to be the time when I have the most problem with it.
Thank you for that, Lisa. I really do appreciate that. And I truly believe that you need to come back, that we need to continue. We need to continue this conversation because there are so many things. I mean, even I have to tell you, Lisa, that even just seeing you and remembering just how kind you were and how good you were with my sister,
Mhm.
that it's the work that you do is incredible. The work that you do is greatly appreciated by me, by my family. Prior it was with my sister, and I think we are just eternally grateful when we have medical practitioners who lead with their heart, who lead and find ways to keep themselves protected, because part of what we end our podcast with is taking care of yourself.
Thank you so much for joining us, and take care of yourselves. Self-care is not a choice, it's mandatory. Figure out how to take care of yourself.
Thank you so much for listening. We hope our conversations provided a unique perspective, opened the door to your own discussions, and offer some comfort. If you have any questions or would like to learn more about anything we've discussed or haven't discussed, let us know in the comments. Until next time, at Liwil Doyexip Noon. Before I go, gratefully acknowledges the financial support of the Indigenous Screen Office.